Hello, this is a short presentation by way of revision on paroxysmal atrial fibrillation. It is supposed to be a review, and hopefully it will be of some practical value when you see your patients with suspected or confirmed paroxysmal atrial fibrillation. It is also annoying for the patients when they repeatedly report episodes of palpitations, and a standard 12-lead ECG does not show it. What does one do? There are strategies which you can apply and make your actions more objective and reliable to improve the patient's symptoms and also to prevent future complications. I'm going to share this presentation with a series of PowerPoint slides, and I will be making some reading of what it shows up on the slides, but this is of necessity in order to emphasize the importance of what has been written. And of course, my microscopic picture will always be with you, and we should see exactly what turns up by way of explanations. So how does one define paroxysmal atrial fibrillation, PAF? Consensus is present in describing it as a rapid onset, irregular heart rate, which begins spontaneously or after a trigger, but then stops within a week, 7 days. Generally, it lasts for shorter durations. Paroxysmal atrial fibrillation occurs when, instead of electrical potentials being generated at sinoatrial node, these potentials are developed in other areas or follow an abnormal path, having been generated in a timely or untimely fashion at the SA node, leading to problems of heartbeats, whether in terms of regularity or pumping enough oxygen. Paroxysmal atrial fibrillation in itself does not pose a direct and immediate risk to life, but it can have serious consequences if it is uncontrolled or poorly treated, leading to fatality. And this is why being able to diagnose, read code, and explain to the patient what the problem is, one should initiate some sort of therapeutic or preventive treatment. PAF, and in fact, the AF is the most common of cardiac arrhythmias. PAF can develop spontaneously or through some triggers, and it can self-resolve in up to 7 days when it is called paroxysmal atrial fibrillation, or it can get resolved sooner or with some sort of intervention. We do not include into the definition of paroxysmal atrial fibrillation triggered by temporary causes such as septicemia, cardiac surgery, pulmonary embolism, and so on. So what can initiate paroxysmal atrial fibrillation? There could be some pre-existing risk factors, and there could be some new triggers or recurrent triggers. So what exactly are these? And so the pre-existing risk factors could include a past history of myocardial infarction, a an ongoing condition of ischemic heart disease, type 2 diabetes, obstructive sleep apnea, hypertension at whatever level, or even untreated, and COPD. There could be some new triggers which could result in atrial fibrillation, such as alcohol excess, and the usual acceptable limit in the UK is supposed to be 14 units of alcohol per week. But sensitivity to alcohol should be assessed individually, as someone could have a long history, liver damage, hypertension developed as a result of excessive intake of alcohol. Smoking is universally accepted to be a potent trigger of atrial fibrillation and paroxysmal atrial fibrillation. How much smoking is bad is a matter for subjective understanding and objective observations. Excessive use of caffeine, such as coffee, stimulant drugs such as LSD, amphetamines, methamphetamines, and others of its kind, general and especially central obesity, which means BMI in excess of 30, unanticipated or prolonged anticipated stress of any kind, whether it is physical or mental, and unaccustomed and uncontrolled and unsupervised exercises physically when one doesn't know the limits. So, how many people are affected by paroxysmal atrial fibrillation? In the UK, we regard that about 2 to 4% of general population, irrespective of age, have this condition. But PAF increases with increasing age. At 75 to 76, the prevalence is between 12.3 to 14.3%. So this is a sizable population, and it makes them vulnerable. Beyond 85 years of age, the prevalence is measured to be at 17.8%. In a well-recognized European Society of Cardiology study suggests that in the European Union, patients over the age of 55 number 8.8 million. And that on the assumption that nothing much would change, the projection is that in 2060, almost 18 million people in the European Union will have paroxysmal atrial fibrillation. It is sad to see that the impact and the frequency of atrial fibrillation, particularly of PAF, can be reduced by preventive strategies, but it is not regularly and wholly applied. So when we talk about atrial fibrillation, we need to recognize that there are various kinds. Paroxysmal atrial fibrillation, which terminates by treatment or spontaneously in 7 days. Persistent atrial fibrillation, which is fibrillation lasting for more than 7 days. Some people call it permanent atrial fibrillation. Long-standing and persistent atrial fibrillation is the one which goes beyond 7 days and lasts for around, but not more than 1 year. If it is resolved with rhythm control, one regards it after the rhythm control to be persistent AF, chronic AF, or AF resolved. Chronic atrial fibrillation is a condition given out of practical necessity because patients are usually elderly and they find their lives to be currently managed in the way that they choose, and they might refuse rate control or rhythm control methods of treatment. And if it is the patient's wish and mutually agreed by the clinical doctor, then one just leaves the patient on a read code of chronic atrial fibrillation and marks it as keeping status quo because the patient has requested. Having said that, it is something preventable, something which can lighten the symptom burden. Why is it that we are not diagnosing and preventing or even suspecting paroxysmal atrial fibrillation with vigor and effectiveness? And this can be seen because, to a large extent, in many patients, paroxysmal atrial fibrillation remains asymptomatic throughout. When the patient suggests that they have palpitations which cause them worries, that means when they have symptoms of paroxysmal atrial fibrillation, they do not record atrial fibrillation on 12-lead ECG. At the same time, when the doctor suspects that the patient might be suffering from paroxysmal atrial fibrillation, the episodes, when they occur and are seen on some sort of a recorder, remain asymptomatic. This is why many patients do not present themselves, do not accept preventive treatment, and therefore they are left untreated and unrecognized and unmonitored. If a vigilant doctor suspects it, he would do a 12-lead ECG, which might not show anything. And on persistent suspicion, he would arrange for a Holter monitor ECG for 24 hours or even up to a week. It might not show it. And then again, the episode might resolve only for the patient to return one day with features of heart failure. And the story of non-recurring atrial fibrillation in the past may lead the doctor to engage with more prolonged assessment. In a study reliably done in the UK, 16.9% patients were monitored by way of screening, and they had shown intermittent paroxysmal atrial fibrillation. And when the baseline 12-lead screening ECG was performed, it did not show fibrillation at the time of undertaking the ECG. And these aspects produce complications in respect of diagnosis. However, why do we need to diagnose it as soon as we can so that we can implement preventive strategies? Statistics teaches us that paroxysmal atrial fibrillation can increase the risk of stroke, embolic stroke, to 5 times. And when strokes occur, both the death rate is higher as well as recurrence rate of stroke is higher. Paroxysmal atrial fibrillation increases the risk of heart failure by 3 times compared to someone who does not have PAF. Just by having PAF, a patient could have and does have an increased all-cause mortality. Another side of the coin is when you suspect and offer preventive treatment by way of an oral anticoagulation, the risk of atrial fibrillation related stroke reduces by 66%, two-thirds. Similarly, a preventive use of oral anticoagulant in AF, PAF, reduces the mortality by 10%. So one would lead to believe that if patients have symptoms of PAF, investigate. If there are no symptoms related to the history of PAF, then look for high index of suspicion and which, if present, investigate. How does one diagnose as a clinician that the patient's description merits further investigation for paroxysmal atrial fibrillation? Pulse palpation is a very reliable feature of diagnosis. If the pulse is irregular, there is a problem. If there is a wide pulse pressure, that means the hypertension is not that bad, but the diastolic hypertension is down. In other words, the difference between systolic and diastolic blood pressures is widened. There is a suspicion then. If the BMI is over 30, or the patient has obstructive sleep apnea, then there is a high risk of suspicion. If there are clinical features of mitral stenosis, such as a loud first sound, opening snap, mid-diastolic murmur, history of rheumatic fever in childhood, and so on, there is a high risk category patient. One should look out for signs of heart failure, lung crepitations, reduced exercise tolerance, shortness of breath, pulmonary and pedal edema. In this respect, when one is suspecting a patient with possible PAF, confirmation through a 12-lead ECG, which, if it shows atrial fibrillation, is deemed to be a gold standard with a sensitivity of 91% and a specificity of 90%, both nearly the same. In this day and age, there are many handheld ECG single lead devices available to everyone, and patients can use it themselves and transfer or transmit the findings to their clinician. And the sensitivity of such handheld devices can be between 94 to 98%, so fairly high. And the specificity would be 76 to 95, slightly lower. A smartphone watch can show irregularity of heartbeat and possibility of atrial fibrillation. Holter monitor of one form or another, self-applied, can show to the physiologist presence of and frequency of paroxysmal atrial fibrillation. So one could do a diagnosis based on these assessments. If the index of suspicion is high, and even a 7-day Holter recorder has not shown presence of substantive atrial fibrillation, one could use implanted loop recording, which is an infraclavicular dissected application of a gadget with a recorder, battery operated, which is connected via thin wires fed through neck veins into the region where sinoatrial node or the irritating or irritated cardiac mass is. Very recently, a patch has been fabricated which contains a battery operated small device no bigger than the size of a capsule that one swallows as an antibiotic, is strapped in the infraclavicular region, and it does not have to be threaded into the vein reaching the heart. From the surface, it picks up irregular heartbeats and records it over a period of time. And this can be Wi-Fi transferred to a recorder. Monitoring can be done by a variety of ways, such as through smartwatch, through Holter monitor, through loop recording, which usually is done for 21 days. But the device can remain there and be activated after a few months again. Risk factors in respect of embolic stroke, embolism, damage to the heart is usually assessed through CHADS2 VASC score. And we will, in the next slide, discuss what this consists of. When the risks are calculated on a patient's health monitoring system, such as a family doctor's office computer, then a large number of patients' objective observed parameters are already present, such as the diagnosis of diabetes, level of blood pressure, whether there is a read-coded history of heart failure, and so on. Other things like age, weight, and gender will also be there. So it doesn't take much time to undertake such a calculation of risk score. Propelled by comprehensiveness, Europeans have now introduced Charge AF score, which takes into consideration many other aspects in addition to those that were looked at by CHADS2 VASC. It is worth remembering that NICE does not recommend these for routine clinical use, but we will be discussing it in the next slide. So, talking about the CHADS2 VASC risk assessment for paroxysmal atrial fibrillation, the way this works is that you or your computer calculates presence or absence of congestive cardiac failure when it would score 1, hypertension, whether treated or untreated, scoring 1. But if the age is over 75, it scores 2. If the age is 75 or under, it scores 1. Similarly, the computer will also suggest, and you can introduce as well, presence or absence of diabetes. If there is a past history of resolved stroke, transient ischemic attack, or episode of thromboembolism, then you give 2 scores. If the age in respect of bleeding assessment in the same substance is between 65 to 74, you score 1. But obviously, if it is more, that is 75 plus, then you score 2. And if the gender category is female, you score 1. 0 is for male. So the computer calculator assesses the points and also thromboembolic risks and rate of frequency of thromboembolism. So when these calculations are interpreted, if it is all zero, then the patient has low risk. Take note that it doesn't say no risk, because the patient would have actually described intermittent palpitation. So 0 is low risk, 1 is moderate risk worth investigating, and more than 1, such as 2 or 3, are high risks, and these should be investigated. One could go further and say, if you took notice of Chad's 2 VASC score and did not act when the score was 2 or 3 or 4, then it could be a form of negligence or lack of attention. Whether you could call it a slip or a lapse, it still is an error, and this error was preventable. So the other newly introduced European-based score is called charge atrial fibrillation, and this is calculated in a complex manner. It is not something which is easy to undertake without the advantage of a calculating calendar. But the computers used in the NHS in the UK probably have not yet been updated to incorporate this figure. But this is how it is actually made use of. Multiply 0.508 to age in year. So if a person is 5 years, multiplied by 1, if he is 10 years of age, multiplied by 2, and if he is 80, multiplied by 20. So you could calculate at 5 years age is 1, 10 years is 2, and so you can multiply in that way. Add to 0.248 multiplied by height, and this is in increment of centimeters. 10 centimeter is 1. 70 centimeter is the usual height of an average male in the UK, and so that would mean 7. Add on to 0.115 multiplied by weight, and in this case 15 kilogram is 1, 30 kilogram is 2, and more than 30 kilogram would result in BMI increase, obesity. Then you add that on to 0.197 multiplied by systolic blood pressure, and the same incremental value as mentioned here is applied, multiplied by or reduced by 0.101 multiplied by diastolic pressure. And so the same technique is applied, and it takes into consideration whether the patient is currently a smoker, currently on antihypertensive medication, has diabetes, has congestive cardiac failure, and has had a history or not a history of myocardial infarction. And so it would give a more realistic calculation. The reason it is not yet updated and it's not in much use and it's not likely to be in much use is that it adds burden of time to the doctor who is keen on providing preventive treatment. So what could be the differential diagnosis of paroxysmal atrial fibrillation? Flutter and sawtooth atrial appearance is well known. Atrial extrasystole, ventricular ectopics, sinus tachycardia, which means with inspiration and expiration there are differences, but that it exceeds at all times at rest 100 beats per minute. Supraventricular tachycardia, including atrial tachycardia, AV nodal re-entry tachycardia, WPW syndrome, multifocal atrial tachycardia, and this is when people have severe pulmonary disease or scattered right atrial disorder, such as with thrombus. When there is sinus rhythm in a patient with premature atrial or ventricular contraction. So these are features which can confuse the clinician in thinking it is atrial fibrillation when these are not. So what are the symptoms of paroxysmal atrial fibrillation? Somehow, I've been able to enlarge my microscopic picture. I apologize for that. It was not deliberate. But it's always nice to see who is speaking and how many errors they have made while reading their own slides. I hope I haven't made many. So a multi-center United States study utilizing 10,000 registered patients of atrial fibrillation, in which each patient had reported one or more symptoms of atrial fibrillation. It was considered that 62% had one or more symptoms, 55% had a mild episode, and 14% had severe episode. So in terms of severity of symptoms, the statisticians worked out that in order of severity and going towards sort of less frequent symptoms, palpitations, shortness of breath on exercise, fatigue, irrespective of workload, giddiness, mainly postural, shortness of breath at rest, that is orthopnea, chest pain at rest or exertional, and syncope, that means vasovagal issues causing collapse of a patient. Now, individually assessing the significance of all these symptoms, palpitations included. So can one say that if a patient has palpitations, this patient reliably has paroxysmal atrial fibrillation? No. The research says that the confirmation level is less than 50%. So here is the issue. A patient has been provided with an implanted loop recorder for 21 days, and he has reported symptoms of paroxysmal atrial fibrillation at a given time, say on day number 15, at a particular time. When the computer analyzes that particular time, there is no recorded paroxysmal atrial fibrillation. So there's a mismatch. And in the same way, if you calculate a patient showing recorded atrial fibrillation at certain times, and you look at their diary of events as to what they felt, they do not record any problems. So these are silent paroxysmal atrial fibrillation occurring and detected via the loop. In other words, only 21% cases are matched in which a patient would say at 3 o'clock in the afternoon on day number 15, I had a bout of palpitation which lasted for 5 minutes. And the event recorder, which is the loop recorder, also confirms this, only 21%. So 79% patients have a mismatch. That is why one could say, are symptoms of PAF reliable? Technically, it is no. But then when it is no, you look for risk factors. Now, we often come up with this situation where a patient reports irregular pulse. And a practical study using a smaller patient size than in the multi-center United States study, the observations in 916 patients showed that in patients over the age of 65, an irregular pulse recorded by the doctor has a sensitivity between 93 to 100% for the presence of atrial fibrillation. In other words, if you feel an irregular pulse, it is likely to be atrial fibrillation at that time. And then therefore you have to take up investigations. The other side of the coin is that the negative predictive value. So if you haven't found irregular pulse, the patient doesn't have paroxysmal atrial fibrillation depending on the age. So we are presuming that the age is less than 75, because after 75, you are likely to have PAF. So one could postulate this. Atrial fibrillation can be confidently excluded if the person does not have an irregular pulse when observed by a doctor. So this is a realistic attitude, but not ignoring patients' concerns, worries, and risk factors. So what are the risk factors which impose a hazard value? So the hazard rate with the risk factors in respect of priority would be age, over the age of 85, even 75, obesity when the BMI is in excess of 30, alcohol intake when it is in excess, that means in excess of 14 units per week, obstructive sleep apnea, which has been observed by somebody else and assessed in a sleep clinic, hypertension when the blood pressure continues to remain above 140/90, heart failure as evidenced by BNP or echocardiogram, mitral incompetence or myocardial infarction history as documented in the past history, diabetes mellitus type 2 if it conforms to the diagnostic criteria, valvular heart disease such as rheumatic heart, aortic valve vegetation. So they impose a different burden in requiring more reliable anticoagulation because the incidence of embolic stroke and embolism to other organs is high. Chronic obstructive pulmonary disease and CKD, chronic kidney disease, stage 3 and above, are lower in line of being risk factors. We are now cutting short as to how you would treat and using what medication. It's a very individual exercise based on your experience, your ability to diagnose, the support that you have of secondary care in the hospital who look at the ECGs, look at the symptoms, advise, or cardiologists who are readily available if you are uncertain. So all these factors dictate how you treat, but you need to treat. So you can treat paroxysmal atrial fibrillation with drugs which reduce the rate or rate control medication. And they are basically of two kinds, excluding digoxin. One is beta adrenergic blocking agents, beta blockers, or rate control medications belonging to calcium channel blocker. So the examples of rate controlling beta blockers are atenolol, bisoprolol, carvedilol, metoprolol, nedolol, propranolol, and timolol. And there are regional policies in relation to age, budget, costs, and who would need to do monitoring tests. The strategy is that rate control should be tried first because it usually works, or it improves, or it simply controls the heart rate, which should be kept around 60 minutes per 60 per minute. And the dose can be titrated slowly. There are obvious well-known side effects of all beta blocker, and I'm pretty sure that most of the members of the audience have awareness of this, so I wouldn't go into that. There are some non-beta blockers which can act as rate control medication, such as diltiazem and verapamil. They have greater side effects, and they are literally second line as rate control medication. If the rate is near normal, but the rhythm is abnormal, then medical cardioversion can take place by suppressing the rhythm, which is abnormal. And this can be done by using sodium channel blockers. An example is flecainide, quinidine, or potassium channel blocker. And the example is imidazole, sotalol, which is a beta blocker but works in this way. So what if the medication does not work and the patient continues to have problems? So depending on the thrombogenicity and your calculations of risk factors in terms of embolic stroke and others, using CHADS2, VASC score, and other that you have just noted with my presentation, you should consider using antiplatelet and anticoagulations. And the single antiplatelet agents would be apixaban, and acetyl salicylic acid is included in this as such, clopidogrel, dabigatran, rivaroxaban. And then in urgency, such as undertaking a hazardous PCI or some other procedure or meeting with some other medical emergency, you could use low molecular weight heparin or heparin. If there is a valve-related thrombogenicity as a comorbidity complicating atrial fibrillation, then one should use the more reliable warfarin and undertake the appropriate PTI tests. In the UK, there is a dedicated anticoagulation clinic which determines the PTI and advises the patient on what strength of warfarin to take and requests the family practitioner into issuing various denomination of warfarin, such as 1 milligram, 2 milligram, 5 milligram. And depending on the PTI, the patient would take appropriate warfarin all at once a day. And he would also be given advice on what would clash with warfarin. Failing medical cardioversion and prophylaxis against thromboembolism, depending on what indications exist, one could undertake electrical cardioversion. And this is now in short supply. A patient is sedated or anesthetized, a defibrillator-like cardiac current is provided, and that it reboots the heart in the manner of speaking. On a long-term basis, one could undertake cardiac ablation of erratic fibers or erratic sources, which could be catheter ablation or surgical. So an angiography type catheter is introduced and it is taken to the site which is known to produce erratic discharges, and using radio frequency sounds or waves, either that triggering area is ablated or destroyed and scarred, and sometimes such erratic triggers emanate from the pulmonary vein area where these triggers are also produced, which produce abnormal excitation of the heart. So ablation can be done via a catheter. One could also use freezing technique of scarring and damaging the myocardial tissue, endocardial tissue, where the abnormal excitation is created or transmitted. Then there is the final mini surgery or robot-assisted surgical ablation. This is on the principle that other techniques have been tried, such as medication, electrical cardioversion, catheter ablation, and the erratic rhythm still persists, leading to substantial risk. And there are other comorbidity related risks. So either opening the chest and exposing the epicardium or myocardium, one could create diathermy-like or laser-like scars which are stitched. They are stitched so that they don't perforate or they don't become aneurysmal. So incising a healthy looking tissue and stitching it in several places, like a maze, on the guesswork as to where irregular fibers generating erratic currents or are transmitting are present, that's where you scar and stitch, incise and stitch. If there is a calculated small area using a robot, the procedure is called mini maze, and it can also ablate the atrioventricular node, which is not so easy because it's present at the top of the septum, and the access to it will have to be from some accessory veins and not through the veins which are normally used to transmit a catheter to the right atrium. So these are the things that I wanted to talk about. And in general, if I can just briefly mention that PAF, diagnosis, suspicion, management, and aftercare, is renewed. And there are types of atrial fibrillation, including paroxysmal atrial fibrillation, which is the most common one, can develop on its own or can be triggered, and that we need to remain mindful of many causes which make or produce high risk factors in producing atrial fibrillation. And there are triggers, well-known triggers like alcohol, nicotine, stimulant drugs. The prevalence is high, but many patients over the age of 85 have it, and they are underdiagnosed and undertreated by way of preventive medication. And in Europe, it's a similar problem which is increasing. So how many types of atrial paroxysmal, how many types of atrial fibrillations exist? We have qualified this according to time and choice of the patient. And of course, why is it difficult to diagnose? Is because it is not symptomatic, it is not suspected, sometimes it's ignored. And why should we persevere in identifying it and in treating it? And that would be because PAF increases the risk of stroke and death, heart failures, all-cause mortality, and that treatment with anticoagulants reduce it by 2/3. So if there are symptoms, you must investigate. If there are no symptoms with PAF, but if there is a high index of suspicion, investigate. So talking again about assessing pulse, BP, weight, valvular diseases, rely on the 12-lead ECG, but also give importance to the patient's own digital devices, handheld ECGs, smartwatch, Holter, and take the matter seriously. If a Holter in 7 days is not able to identify and the patient insists that they have intermittent palpitations, one can use implanted loop recording, newly introduced patch recording, and then one can apply the CHADS2 VASC score and newly introduced Charge AF score. And we have described how to calculate the CHADS2 VASC score, and that this is the interpretation. The Charge AF score introduced by Europe is very complicated, time-consuming, and above all, it does not contribute that extra much to the benefit of the patient for it to be utilizing the clinician's time on a regular basis. The differential diagnosis relates to different forms of arrhythmia. The symptoms could be those that are regarded as being produced from anxiety neurosis, asthma, chronic fatigue syndrome, or anxiety. And so if someone presents with an irregular pulse, we must take it seriously. Remembering in general therapeutic terms that atrial fibrillation can be confidently excluded if the person does not have any regular pulse. That is, at that time of assessment. These are the risk factors. And of course, we can reduce the rate, we can alter and control and improve the rhythm to normal by various means. And these are medically possible. In addition, because of the risk of comorbidity and uncertainty of paroxysmal atrial fibrillation, one could and should consider antiplatelet and anticoagulation in various settings. And if these don't help, to consider electrical cardioversion and or going on to cardiac ablation after the electrical cardioversion has failed. It could be done via catheter ablation and surgical, and we've talked briefly about this. Thank you very much, and I hope that I have contributed to something useful as far as this presentation is concerned. I certainly have learned how to magnify my picture and how to shrink my picture, which I didn't know. Thank you very much. Look after yourself, protect yourself from COVID, and remember the masks, remember social distancing, remember doing lateral flow tests, and where positive, must do PCR tests. Inform your clinicians, follow their advice, go through the isolation requirements, do not travel unnecessarily, allow it to pass, and it will pass. Thank you very much.